This is one of the outreach programs that we try to utilize to deliver information to the population. As you're learning from us, we hope to learn from you, from any other questions that you have or personal experiences that you may share with us. We start this off with talk about peripheral vascular disease. And you may wonder why, as cardiologists, we're talking about this. And I hope that during the course of the presentation it will become more apparent why this is important, why we even start the lecture series with this topic, because it's not just purely based on what you see on the title up there. As cardiologists, we're not just focused primarily on the heart. In fact, our certifications are for what we call cardiovascular diseases. And in a nutshell, that's considered diseases of the heart, but also of the blood vessels of the body. It affects most organ systems throughout the body, and it includes an array of medical issues, many of which are interrelated. Treatment strategies often overlap in different areas, and you will see evidence of that as we talk about this. And it can require multiple different doctors or specialties to be involved in treating this sort of disease process. Some types of cardiovascular disease you may be familiar with, some may not readily come to mind. And we're going to gloss over some of this, and we'll spend more time on others, and maybe in another forum we can learn more about some other features up here. Heart disease is always at the top of that list. It's the #1 killer of all Americans, whether it's black, white, male, female, it does not matter. This is the thing that takes most of us away from here when we depart from Earth. Peripheral artery disease is the subset of peripheral vascular disease that we will spend time talking about today. Stroke and carotid disease, sometimes people lump this into the peripheral artery disease section, though it is technically a different animal, but as you will see during this talk, there's a lot of overlap in these diseases that we have up here, and as we attempt to treat one, at the same time we're attempting to treat all of it. Renal or kidney disease is one feature of cardiovascular disease. Some people on dialysis are very much familiar with this. There are blood clots and problems with varicose veins. And this is a simplified list of problems up here, but this is some of the bread and butter of what we talk about. Now, if you look to the right of the screen, these are technically considered risk factors for disease. I think they're important enough that I consider those cardiovascular diseases in and of themselves. It's unusual for you to have anything on this left column without having one or more of these things on the right column. We talk a lot about the heart, but when we're having discussions about this, basically we're talking about all of this. And, you know, if you're interested in all of these names, I can give you a copy of this later. I'm pretty sure we can skip on through this. So, when we talk about peripheral artery disease, or PAD, you may hear about some of this in the press. PAD, most times when we're talking about it, we're talking about of the lower extremities of the legs. That's not the only place where peripheral arteries exist, but that's the mainstay of what people talk about when they're talking about PAD. It's atherosclerosis or plaque cholesterol deposit buildup in these arteries. It's affected by, people who are affected by this may not feel any symptoms for years. And we'll talk about this in just a moment. Ultimately, it could lead to symptoms of reduced blood flow or signs that there's some compromise in the way the leg looks, functions, or behaves. It may be threatened by plaque buildup and lack of blood flow. And it does require serious attention, and I'll draw your attention to what I mean by that. There's more on the line than just whether or not someone has symptoms with PAD. It can lead to limb-threatening issues, whether they be ulcers that are not healing up, infections of the legs, deterioration of bone. A lot of people are familiar with at least the terminology gangrene, or even the loss of limb. But it can be a marker of a more generalized cardiovascular problem, and that's where the importance lies here. Now, I like diagrams like this, and I'll tell you why. number one, with most medical talks, you're bound to get at least one diagram where you can't read a daggone thing that's up there. It's almost a guarantee. And in fact, if any of my colleagues coming behind me does not show you at least one thing that you cannot read, don't believe a word they say. I'll tell you what the importance of this is, because most peripheral artery disease discussions, whether they're truly academic lectures or lectures to the community, will show something like this. And we're going to simplify it. Claudication is the typical symptom that people have from PAD. And we'll discuss that a little bit later. But only 10 to 35% of people with PAD have typical symptoms. So the other folks may either feel something that doesn't necessarily make them think I have a circulation problem, or they may not feel anything at all. One of the take-home points, though, is that if you take people with PAD, only about 1 to 2% of them will actually have a problem that truly threatens loss of a leg, loss of a limb. That's not to trivialize that, but the majority of people do not lose their limbs with this problem. We see extreme cases of this, but the majority of people do not. The biggest point, though, is that if you take people with significant PAD and you look at them over the course of a 5-year span of time and think about what causes people to die, the majority of people, 75% or more, actually die from some sort of cardiovascular problem. Most of them heart attacks and strokes. So claudication. Now, if you sit down in one of our offices and we ask you, have you had any claudication, we're probably doing you a disservice because we're not making it clear exactly what we're talking about. Claudication is the technical term for what we think about when people have truly classic textbook symptoms of PAD. And it's usually defined as discomfort, usually cramping or burning, that can be in the hips, thighs, calves, usually comes on with walking or some sort of exercise, usually resolves after several minutes of rest. That's the classic textbook definition. But as I told you on the previous slide, only 10 to 35% of people with PAD will come in and tell us that. Sometimes we're digging more and more to try to tease out, are you really having problems that should make us think there's evidence of peripheral artery disease? It can be more of a progressive problem that can lead to more functional limitation. You're able to walk 2 miles 1 year. The next year, your legs are bothering you after you walk half a block. There's something that's limiting your ability to function. It does not necessarily mean it's this, but it makes us think that. If people truly have pain when they're not doing anything, and that pain is due to a circulation problem, that could be a very serious and very dangerous problem. It could be accompanied by discoloration, tingling, numbness, the legs feeling cold, the feet feeling cold, as a lack of circulation to the lower extremities. There are a lot of things that may sound like PAD that may not be PAD at all. So we call these the masqueraders. A lot of folks have back pain, herniated disc, spinal stenosis, if you've heard that terminology. Some people have problems with arthritis or sciatica, sciatic nerve compression that can cause discomfort in the legs. Neuropathy, especially in diabetics where there can be damage to the nerves that supply sensation down to the feet that can cause a lot of burning, pain, tingling, numbness. Fibromyalgia is a discussion all of itself. Muscle problems, restless leg syndrome, and sometimes people cramp and we have no idea why they do so. It doesn't necessarily mean there's a circulation problem. So you can see how muddy this could be. And in fact, you can have an 80-year-old with diabetes that also has had 2 back surgeries, and you can imagine they can have a combination of these things and they can make it very confusing. So how do we diagnose it? Well, one thing is the history. The majority of what we do as cardiologists is we talk to you a lot. We ask you a lot of questions. Sometimes we ask you the same thing today that somebody asked you yesterday. And it's annoying, but it's really to kind of get to a point. Much of what we do resides on what patients tell us. 90% of our ability to diagnose things usually starts with this. So if I'm getting a history of classic claudication, leg discomfort due to poor circulation, I'm already thinking about the next set of things I may have to do to further evaluate you for that. But I'm also thinking about, you haven't told me that there's a heart problem. I need to see if I can uncover, are you having any problems that may be specific to the heart as well? Physical examination, a lot of times in the office when we're looking at PAD, we may ask you to take your shoes and socks off as we're assessing your circulation. This is one called an ABI, or ankle brachial index. We'll talk about that in just a moment. Ultrasounds, CAT scans, MRIs, and an angiogram or an arteriogram. There are a lot of community health screenings that attempt to raise awareness of this. Traditionally, there have been I saw a lot of patients come to see me, they'd have a triple screen. They'd have a carotid ultrasound, abdominal aneurysm test, and they'll have ABI, or circulation test for legs, all for the low cost of $99. Now, none of that is specifically heart-related, but it's vascular or cardiovascular. Our health screening with the van that we see out front does all of those things, plus they do some imaging of the heart with ultrasound and with EKG, and blood testing to look for risk factors of heart disease. So these things are very helpful. If you do happen upon one of these health screenings, feel free, and I encourage you to take that information back to your primary care provider so that they can incorporate that into their treatment strategy of dealing with your overall health status. So ankle brachial index. I put this in here really because this is the simplest. I mean, if you ever have this done, it'll seem like anybody can do it to you. It's the simplest thing in the world, except for this little ultrasound probe. But it's a measurement and comparison of your arm pressures to your ankle pressures. And we also use a little ultrasound probe to help us look at certain patterns of blood flow as they get down to your feet. There are more complicated ways to do it, there are more expensive ways to do it, but the simple screen is to look at arm pressure versus leg pressure. Now, you may not like numbers, so I'm going to simplify it even further. Usually, the pressure in your arm, if you think about the top number of your blood pressure, says 150. And then we measure the pressure at the ankle. It usually should be about the same. If not, the ankle pressure generally is a little bit higher. So if it's 160, 170 in the ankle compared to 150 in the arm, the circulation is generally pretty decently preserved, at least at rest. Sometimes if we get you up and walk you and exert you, we may see something different. But at least a resting test is that simple. However, if I check your pressure in your arm and it's about 150, and then I check it down at your foot and it's about 70, and that doesn't tell me exactly where there's a problem, but it tells me somewhere between here and your feet, there's a hang-up of blood flow getting down to your ankle. And it doesn't say if there's one blockage, if there's several blockages, if there's an 80% blockage or something's completely occluded or completely closed off. But it tells us there's something interfering with natural blood flow all the way down to the foot. That generally leads to some other discussions about, well, what do we do about it? So what's the potential treatment? Now, I'll say the top two are fair game for everyone with peripheral artery disease. We look at the risk factors. We talked about the high blood pressure, the cholesterol, the diabetes, the tobacco. We'll talk about a few others. You have to do that no matter what else is done, because these are the things that are encouraging the problem. If we do not address those things, we're putting a Band-Aid on the issue and not getting to the root of the problem. Number one treatment strategy, other than that, for people with peripheral artery disease is walking, exercise. It's almost like writing your prescription for that. Aspirin, 81 milligrams daily, walking 3 times, 5 times, 7 times a week for 15 up to 45 minutes a day. That's generally like writing a prescription. No matter what else we do to treat this problem, these two at the top have to be one of the mainstays of the treatment strategy. There are certain medications that we can think about with peripheral artery disease, but as we really talk to you about these things, you will see a lot of that medical therapy is based on how do we keep the blood sugar under control for your diabetes? How do we keep the cholesterol as tightly controlled as possible? How do we keep the blood pressure under control? There are very few medicines specifically directed at PAD, but most of the medical therapy is trying to quiet down the whole plaque buildup problem at the root of the issue. There are ways that we intervene on people, and that can be with angioplasty or balloon angioplasty or with stenting. A lot of people are familiar with this with respect to the heart, people having heart blockages, getting balloons and stents in the heart. But we can do that in the legs too, in select cases. Sometimes that's not indicated, sometimes much more than that is indicated, where we can actually physically remove plaque and use lasers or what we call cutting balloons or cold temperature cryoprecipitation and things, very technical things in there. But the whole issue is to try to improve circulation by relieving obstructions of blood flow. There are times we need to get a surgeon involved. Sometimes this PAD talk is given by a vascular surgeon. They do a lot of the same work that we as interventional cardiologists do. Plus they do the additional step of if you need an operation, they're the ones that do it. But the majority of the vascular surgeons today don't start with surgery on your legs. They start with balloons, stents, rotor-rooters, and that sort of thing to try to improve blood flow if there's a PAD problem. Worst case scenario, sometimes it leads to amputation if there's a severe enough amount of obstruction of blood flow that we're starting to threaten or damage the tissue in the leg, foot. Sometimes the only option is to remove the foot and do an amputation. So again, the risk factors, we won't belabor this other than to belabor it. Hypertension, high cholesterol, diabetes, tobacco. Again, those are the top four that we will keep hounding you about as we talk about cardiovascular disease. We cannot get anywhere if we do not address these problems. Metabolic syndrome is one that kind of takes features of being overweight with some component of the blood sugar is not quite right, the cholesterol could be better, or certain portions could be better, the blood pressure is not dramatically abnormal, but it's not normal. But we need to get on top of all of those things, and it falls into a category some people used to call Syndrome X. Inactivity, we need people up and walking. Again, exercise, walking as one of the primary treatments for peripheral artery disease. We will always recommend that unless you're unable to do it for physical reasons. Obesity, we all have to keep our weight under control. Lose weight, that's part of the treatment. That helps to control blood pressure, control cholesterol, control blood sugar, but it helps us get more physically active, and it keeps our stamina up, and it also makes us more functional. Certain drugs wreak havoc on the vascular system, and stress, believe it or not, also has an adverse effect on the vascular health in a lot of patients. It's easy to underestimate these things because they don't always make you feel bad. A lot of times if the sugar is high, you don't necessarily feel bad from it, but it's not what it's doing at that moment. It's what it's doing over the course of months and years to your blood vessel system. But this is a lifelong treatment. It's not a one-stop, let's take care of this problem, we don't have to worry about it anymore. This is something that we have to address from the moment we get on top of it. Prevention is obviously the better way, but as we treat a disease process, we have to do this lifelong. There are things that we can't change. How old you are, whether you're male or female, what your race is. Socioeconomic status has a lot of impact on people's availability and access to health care. We can have a completely different discussion, I'll let Chuck do this later, on the Affordable Care Act and things like that. I'll leave that to the chief. But the whole point of that is to try to deliver health care to the masses of people who need to have medical attention. So just a few little schematics and then we'll finish up here. If you look at this, this is just a blow up of, again, this is the leg circulation, and what's in red is the arterial system. This is what a healthy looking artery look like. This branch is nicely wide open and healthy looking. And then this branch has this yellowish plaque buildup, which happens in the wall of the blood vessel. And as you can see, it starts to encroach on the opening of that vessel so that there's a blockage in there. This area is narrowed down due to the plaque building up and narrowing down the artery so the circulation does not get there as it normally should. In many cases, this will produce an abnormal ABI if we're comparing your arm versus your leg blood pressures. What can you do about it? Well, in the simplest form, there are times that we can get through an area of plaque buildup to expand an 80% blockage down to 10%, 0%, and it stays open and you do fine. Sometimes it may not actually stay open, and a stent, which is like a scaffold, gets put in there, and when the balloon comes out, the stent stays. We don't take stents back out. Over the course of months, weeks or months, these stents become incorporated into the wall of the blood vessel. So there's a layer of cells that begins to cover that, and then it gets embedded in the wall. So there are a number of times where patients will come back and tell us, well, the doctor removed my stent. That's not what happens. They may have treated inside the stent, but you don't want to have your stent removed because that means somebody might be doing an autopsy or something. This is kind of a picture of what a stent looks like, and they come in different forms. If you've seen the spring on the inside of an ink pen, it kind of looks like that. And heart stents have the same kind of idea to them. They're smaller than the ones in the leg. These leg arteries are much bigger than heart arteries, and they're much longer than heart arteries. So a lot of times the same kind of idea, but different technology is used to treat blockages in the leg. We also have heart stents that have medication coated on them to try to retard the ingrowth of new blockage into an area that's been treated. Now we have stents coming out on the market that are used for the legs for the same reason, and balloons that have medications coated on them to try to keep blockage that you've treated by expanding it from trying to narrow back down. I show this for two reasons. This is the way these things are formatted. This side over here to your left is the right side, and this side is the left side. And two things you can see in this diagram. This is the blood flow coming down to about this part, and then it branches off to go into both legs. On the right side, you don't see that branch. It's completely gone. And on the left side, you see about a 90% blockage there. What they're showing you is, after doing a balloon on it, that 90% blockage has been pretty much resolved. But you also see blood flow going down here because at some point they used a balloon to open that up too. This is an example of the collateral blood flow I talked about. This is coming down the left leg, that's right around the groin area. You're right below the groin. This branch here is the main channel that takes blood flow down to your foot. It stops right there. If you follow this picture all the way down, then it picks back up here, keep coming down, is absent, and then you start seeing remnants of it fill in there. And you may ask yourself, well, how can you go from being completely closed to now I see some blood flow down here? Well, one thing is because of this branch over here. You see these little twigs starting to sprout out, and then you follow it all the way down here. These twigs begin to fill in blood flow there like the body tried to do a natural bypass. And that's the collateral blood flow that we're talking about. Now, does this replace what normally should be coming down this channel? No. But it could be the difference between the leg potentially reaching gangrene or not. It doesn't necessarily mean that you will not have pain in the leg when you walk. But having some blood flow get down to that foot is better than not having any get down there. This is an example of someone's right leg, right below the groin, where this artery that should be coming down here is completely missing. And this is a diagram of showing the result of actually being able to open this up. Now, I do procedures like this. I've got two members of our cath lab staff here, Jessica and Amanda here. They help us do these procedures. We can't do them by ourselves. I would say most patients that have this, we've probably been able to get through about 80% of these types of blockages and get balloons and stents in there to restore blood flow. Well, that's not 100%. That means at least 20% of people, we're not able to get this open like that. But it could be the difference between someone needing to have surgery or not. Bypass surgery, the surgeons sometimes have to put new plumbing around blockages for us. And a couple of different things, and we won't get too technical with this, but if you look up here, you see plaque in this aorta, and then in these upper arteries here called the iliacs, and the surgeons come in and put a bypass that kind of looks like some new pants legs around the blockage. Sometimes this is done with vein, and sometimes it's done with synthetic graft material or artificial graft material, where they basically do new plumbing around the blockage to get blood flow down to the legs. And this is another one where they can do it because of blockage in the thigh artery, and come and put a bypass up around it and tie it in down below it to give a new circuit or a new plumbing area of blood flow down to the foot. Sometimes the surgeon may open up the artery and shell out as much plaque as possible and then repair it. That's traditionally done for carotid arteries for people who have tight blockages in the neck that can lead to strokes, but they can also do it in some arteries down in the legs as well. Worst case scenario is something like this, where you have gangrene, and we all know people who've had this, or we've seen something like this before. This is worst case scenario, and many times if you have this and then try to restore blood flow, it may improve some of it, many times it may not improve any of it, and then we're talking about a surgeon coming in and removing some amount of tissue with an amputation. So in conclusion, PAD, peripheral artery disease, is one element of a constellation of cardiovascular diseases. And again, many people aren't necessarily dying specifically from this, but they may be dying from some cardiovascular problem, be it heart attack or stroke. That's where the majority of us are going to leave this earth. Risk factors and treatment strategies are similar to that of atherosclerosis elsewhere in the body. If you have your cardiologist talking to you about you've had a heart attack, what do we need to do treatment-wise thereafter, a lot of it's going to sound like the same thing we've talked about for the PAD. If you've had a stroke, the treatment strategy may sound like exactly the same thing we're talking about for someone with PAD. Failure to do justice to these problems can lead to more of an issue. It can lead to limb loss, or it can even lead to death. This cool little guy up here, that's my son. As cool as he may look, he won't be so happy if I miss his basketball game, which tips off at about an hour from now. So I'll leave the rest of the program to our trusted staff and you fine people here. We thank you for coming out today.